So everyone else, if you want to slowly start coming back, switching on your cameras for our last session, which will be afternoon report. Andrew Kim, one of the PGY3s, if you don't know him already, which I'm sure all of you do, has a very interesting case for us. Whenever you want to go ahead and get started, Andrew.
Sure. Thanks for tuning in, everyone. So this is a case that I saw as a second-year resident on one of the consult services. So should I read, or does somebody want to volunteer to read the HPI?
We can do it. We can do it, Andrew. Don't worry. 49-year-old gentleman with no known past medical history who was referred to the ED for further evaluation after he was found to have several lab abnormalities during a recent outpatient visit. He had initially been seen in the urgent care setting complaining of several weeks of episodic hiccups occurring primarily in the immediate postprandial period. What nice alliteration, which would then trigger non-bilious, non-bloody emesis and result in relief of his hiccups. He otherwise denied any bloating, excessive belching, or flatulence. He was started on a trial of Reglan, which resulted in temporary relief of his hiccups. He was referred to a gastroenterologist several days later for further evaluation, at which time he was ordered for labs and routine imaging.
Okay, thank you. So does anybody have any questions before I go to the next slide? No? Okay.
You saw him inpatient?
Yeah, so this was I saw him at Morningside on the medicine service. I mean, I was a consultant, but he was admitted to one of the teaching teams.
Mantej is asking if there's any weight loss.
No weight loss.
Any alcohol use?
So no recent alcohol use. We'll get into more of his background later, but he had a history of alcohol use disorder, but he said he had been sober for almost 3 years at the time we evaluated him. Nope. Yeah, no abdominal pain. Oh.
Archana wants the big reveal. Which lab abnormalities?
We'll get there. So this was the way this case is structured is a little bit atypical in the sense that, the time of contact was, like right after he was admitted to the hospital, but just sort of as a pretext, like he had been seen. The reason he came to the ED in the first place is because of this workup that I'm about to reveal, which was obtained like 3 days prior. So here are the labs. So basically he had been seen, I don't think this gentleman had a PMD that he had been following with on a regular basis. What I was able to get from chart review was that he had been to urgent care a couple of times. And then this was maybe like a month before this hospitalization. And then a few weeks after that, he was, seen by GI. So we have basically a BMP, a CBC, and the GI doctor wanted to get a chest x-ray just to rule out any sort of anatomical causes of his hiccups, which were really his chief complaint.
Well, I guess there's lots of things highlighted in red there. What things do people notice, or what abnormalities are really grabbing your attention? So Ariella, yeah, the creatinine and the calcium for sure.
Mm-hmm.
And did we have a baseline for this patient?
So he hadn't had any regular medical follow-up, like I said, but we did. He had interfaced with the system before. So the most recent labs prior to this were from maybe about 1.5 years before. Including a Chem 7, and at that time he had a normal creatinine. He had a creatinine of about 1.15, which I would consider normal in this patient. We'll get to the reason why in a little bit. it's on the higher end of normal, but let's see.
Mantej is commenting on the AKI with the BUN creatinine ratio and the hypercalcemia, wants to know what the albumin is. He seems suspicious about the anemia.
Yes, good point. So the calcium, so this calcium was from the BMP, and the specific assay that they used, this was not, they didn't get a, they got an albumin separate. I forget if they got an albumin separately. It wasn't a comprehensive, it was just a basic, but we have an albumin from, you know, around this time, and it was normal. So this is a true corrected calcium. The anemia, I forget on those labs from like a year and a half before, I think he had a normal hemoglobin of like 12 to 13. No bony pain. Let me see. Is it a normocytic anemia? Yeah, the MCV was normal. Sorry, I should have included that info. So, all right. So moving on. So some more backstory. So basically, review of systems. Again, this is, you know, more of a subacute chronic hiccups, non-bilious, non-bloody vomiting, which was triggered by the hiccups, but no other like GI symptoms, like no abdominal pain, no diarrhea. You know, he had no altered mentation. I mean, even before we saw him, there was no comment on confusion, like either by the examining physician or, you know, collateral from somebody who knew him. I believe I mentioned here, yeah. So basically, you know, this guy is a competitive bodybuilder. That's his occupation. So he's a very muscular guy. Like he was like maybe 5'10", you know, 250 pounds, mostly muscle. So that's why I, you know, when I saw the creatinine of 1.15, you know, from like a year and a half prior, like I consider that that's probably on the higher end of normal, and probably could at least in part be explained by his muscle mass.
Sorry, Kirtan, I just had a question and a comment. So I guess in relation to the bodybuilder, any steroid use?
Yeah, good question. So, I mean, you know, this guy definitely did have a history of anabolic steroid use. I don't know exactly how forthcoming he was about it. I mean, he admitted to remote use. So we saw him in June. So, you know, for those of you who don't know, like, you know, people who compete in this sport, there's like an on season and an off season. On season meaning when they're competing and, you know, they're following a very strict dietary regimen. So this guy was presenting in what we call the off season. And he said that, you know, in the past when he would generally tailor his use of anabolic steroids and other things, you know, based on the time of year. But in this case, there was no like acute or recent use.
Andy, I have a question. Maybe that high creatinine was normal for him if he was like very muscular.
What was that, Uras?
Like maybe that high creatinine was normal for him if he was
Yeah, that's what I was saying. Yeah, exactly. He had he had a lot of muscle mass at baseline. So that's why I mean, if I saw that high creatinine and like that 1.15 or whatever it was in isolation, I probably would not have, you know, thought much of it beyond that.
Dr. Singh also asking which of the lab abnormalities could be attributable to his hiccups, which Kirtana correctly identified as uremia. Mantej continuing saying you seem to know a lot about the seasons, Andrew. Not sure what he's trying to get at. And then Dr. Singh also suggesting his alcoholism could also be the cause or source of his hiccups, which seemed to be the thing that brought him to a doctor in the first place, right?
Yeah. Okay. So here's his physical exam. So this is his exam. This is our exam, or I guess the admitting team's exam when he came to the ED a few days later after getting those labs. So. Any comments or?
I guess, do you want to describe, I guess, what the patient was like when you saw him, when you did your exam, if it was like this as well, if there was anything, I guess, remarkable, unremarkable that you saw?
Yeah, I mean, I think if you, without seeing this patient in person, I mean, I think, this exam looks quite unremarkable compared to what we saw, I mean, especially with that degree of hypercalcemia, uremia, and, renal failure, you would expect probably somebody who's like profoundly volume down. Oh, I'm sorry. Whoops. Somebody who's like profoundly, dry on exam. You can, complaining of abdominal pain or having altered mentation, altered sensorium, but there was actually none of that. He was actually very, calm, pleasant. I mean, he was very cognitively intact despite all those lab abnormalities. And again, we don't know how long his labs had been deranged like that. So the only thing is it was a little hypertensive, but no symptoms attributable to that. No previous diagnosis to our knowledge of hypertension in this guy. No asterixis.
So with that, does anyone want to take a stab at the problem representation? Putting together the history, summarizing the physical, and I guess to paint a picture of maybe what we're dealing with here. I'm going to pick on Ariella, if you could maybe help us out. And Andrew can go back through his slides as well, if that's helpful.
That's okay. He was 49, middle-aged man with no known past medical history, but known bodybuilder, coming in with presenting with a complaint of hiccups, found to have acute AKI, anemia, hypercalcemia, hyperuricemia, and new onset hypertension.
Okay. Yeah, so I mean, I think that's pretty good. I had something similar. So, the demographics, as you mentioned, this is a middle-aged gentleman with, not much of a past medical history. I just mentioned the, history of alcohol abuse, even though he had been 3 months sober, or 3 years sober, excuse me. Recently evaluated in the outpatient setting for recent recurrent paroxysms of intractable hiccups, nausea and vomiting associated with dyspepsia, treated with antiemetics and over-the-counter antacids. Did I mention previously, so prior to coming here, he had been started on a trial of Reglan, which did, so basically that was kind of, the extent of his treatment, which did provide him some relief. And subsequently referred to the ED for workup of several electrolyte acid-based arrangements.
So I guess with that, what are your differentials at this point? Or I see, so Ricardo's saying there is also hypochloremic metabolic alkalosis, right? Yeah, so everything that, if we want to go back to the original BMP that we had, so everything you can see lit up there. So your low chloride, increased bicarb, your elevated BUN creatinine as well. So at this point, I guess, what differentials are you thinking and what workup do you want to do? I know it's a bit unusual in the sense that some of the workup has been started outpatient, or you kind of have some of the pieces of the story together. But if you were to get this patient to you in the emergency department, what are you thinking is going on and what do you want to order?
Hi. So I would start with, like, for the hypercalcemia, start with BTH, repeat the calcium and then PTH, just to see if, like, it's driven by the parathyroid or no. And then we'll do the rest of the labs to see like the cause of it. And also for his chichinuria, I mean, it might be driven by the same like etiology that caused the hypercalcemia and also the hypercalcemia as well. But like just we can do the initial labs like UA, urine lights, and US renal and bladder, just to make sure there is nothing else going on. And also maybe calcium in the urine might help us as well with like with the etiology of the hypercalcemia. I guess this is for like a initial, and we'll add also lipase and LFTs as well for the initial workup.
So I guess your initial thinking, Noor, I guess, is the hypercalcemia is the primary etiology, and I guess figuring out what caused that. Is that correct?
Yes, yeah.
And I see Mantej is asking for protein electrophoresis for the calcium. I think he mentioned myeloma earlier. Dr. Singh has a question specifically for you, Ricardo. What part bicarb would you expect with an AKI? And then Mantej, we'll give Ricardo time to think about that. And then if Mantej, next question was, do we have any more info on the stuff he was taking? Milk alkali syndrome, not sure if that explains everything though. So I think he was on like supplements and things like that, Andrew.
Yes, he was. So just going back right here. So he wasn't on any prescription medications, but he was taking a lot of supplements. Again, I honestly don't know, how reliable of a historian he was. He mentioned all these things. He didn't specify some. I mean, with some of them, he specified amounts. But we were under the impression that this was not like an acute ingestion. These were things that were part of his regimen on and off. And, he had been taking within a couple weeks prior.
And I forgot to ask, did we have a UA?
He did not have not a routine UA. Like, you mean in the outpatient setting before he came?
Mm-hmm.
No, they didn't get UA.
So I think Abhinav is asking as well about the gas. So I guess we can add that to the workup we want to do. So UA and a blood gas.
Yep.
Ricardo also saying in response to Dr. Singh, we should have a metabolic acidosis with a normal AKI. So something atypical about this.
Mm-hmm.
And then Dr. Singh has a question for Mantej this time. So serum protein electrophoresis is a good test looking for monoclonal protein. Is there a better screening test? Ariella also asking for renal ultrasound. Absolutely.
Mm-hmm.
And I guess what other workup would you guys want to do? So Mantej's answer is looking at your protein and your albumin immunoglobulins to look for protein gaps. So looking at your labs that way first.
Mm-hmm.
But the correct answer is immunofixation. Cheaper and quicker. Nice.
Okay. Yeah, so these are all good answers. And again, we'll get to what was actually ordered, which you guys pretty much hit on everything, maybe like minus one or two things. So
I also have one more question.
Sure.
They didn't have any injections, right?
You mean like IV drugs or?
No, like they are doing some sort of, I don't know, oil or some kind of injections in their muscle.
Oh, like synthetic oil and stuff like that? No, I mean, we didn't ask him, but no,
Okay.
I don't think so. Yeah.
Okay.
That's a good thought though. Yeah, in this kind of guy. All right, so basically, you guys all came up with some very good differentials. I mean, essentially, there's this case kind of involves a lot of different, simultaneously occurring acid-base and electrolyte derangements. So I sort of, created a list of differential diagnoses for each of them. And that is not to say that none of these are like mutually exclusive. Obviously, there can be overlap between all of these. So starting with the hypercalcemia. So, you guys mentioned, like what kind of workup you'd want done. Obviously, when we're working up hypercalcemia, one of the first kind of branch points, if you look at the algorithm, is we want to see if it's a PTH versus non-PTH mediated process. So, commonly, it could be due to a hyperparathyroidism from a hyperfunctioning adenoma. So that would be the most common PTH driven. You can also have hypercalcemia of malignancy. That could be mediated by like PTH related protein. Milk alkali syndrome, some of you guys mentioned that. Hyperthyroidism, local osteolytic lesions. I know some of you guys asked about bone pain. Granulomatous diseases like sarcoid could also do it. One thing to know is like, the degree of hypercalcemia is pretty alarming. I mean, usually we tend to see higher degrees of more profound hypercalcemia, at least in my experience, like more with malignancy than primary hyperparathyroidism. I mean, the calcium that this guy had, 13.6, was like on the higher side. So that was definitely part of our, that was definitely high on our differential when we saw him, just based on that alone. And then going to the acute kidney injury. So we're calling this an AKI because we presume that this gentleman, did not have any known CKD at baseline. This was all acute renal failure. So again, I didn't differentiate among like pre, intra, and post-renal causes. We'll get into the workup for that on the next slide, but these are the common things that you guys are probably all familiar with: pre, intra, post-renal, and then you can also further characterize the renal failure as being proteinuric or non-proteinuric. So you can think of your nephrotic and nephritic syndromes. And then finally, for the metabolic alkalosis. So, obviously in this gentleman, this guy did have a history of, paroxysmal hiccuping with nausea and vomiting. So that's definitely up there. The metabolic alkalosis could be compensatory for a respiratory acidosis. And again, we will show the blood gas so we can sort of better characterize the acid-base disorder. Other things, these are kind of things that, I mean, I haven't seen them, but, these always come up on boards. You have things like the Barter and Gittleman syndromes, which are basically like hereditary defects at the level of the tubules. High dose penicillin, aminoglycosides. Like commonly we see patients who are in the hospital getting aggressive diuresis. They can develop metabolic alkalosis as a result of that. So let me see. Okay, so this was the repeat workup on admission. So this was after he came to the ED. This was like I want to say 3 to 4 days after those initial labs that I showed you earlier. Dr. Singh, has he been using sodium bicarbonate? No, the only thing that we got on the list was Tums. So close, not sodium bicarbonate, but close. So yeah, basically here are the labs. Tums is basically calcium carbonate. Yeah. So basically we repeated a BMP, a CBC. These are the calcium, mag, and phos respectively. This was a VBG. I should have included, I'm sorry, I forgot to include the LFTs on here, but from my recollection was that maybe aside from a slight elevation in the ALK phos, which was not followed up with any other ancillary workup, it was pretty normal. And then here's some coags, which were again normal.
So I think with this, we can see kind of the BMP, kind of the same, worsened than his outpatient one, and then the VBG that we wanted that we have here. So I'm just going to start sharing my screen just for a few minutes, if that's okay, Andrew. Okay. So I guess for this case, as it really hinged on or was related to like the acid-base disturbance, the reason the patient was referred to the ED, and I guess a huge reason, like one of the biggest abnormalities that we see. So the labs that we had for him showed a pH 7.48, a bicarb of 44, and a PCO2 of 59. So I guess quickly kind of going through really the stepwise approach that we have or should have when approaching ABGs, VBGs is identifying your primary disorder, right? So quite simply, is it acidosis or alkalosis you're looking for? And using the cutoff of 7.4. So anything less than 7.4 as acidosis, anything greater alkalosis. And with that then, seeing if you're dealing with a metabolic or a respiratory picture. So we know our pH is proportional to the bicarb, meaning if our bicarb goes up, our pH is going to go up. And then our pH is inversely proportional to our PCO2. So if our PCO2 goes up, our pH is going to go down. So we can see with this, our pH has gone up, it's alkalosis, our bicarb has gone up, looking at metabolic alkalosis. And then your compensation for the primary disorder should always be in the same direction as the primary disorder, meaning if your PCO2 goes down, your bicarb should go down to compensate appropriately. If your bicarb goes up, you should expect your PCO2 to go up. And I guess an easy way to remember it or to kind of quickly look at your ABG, VBG, kind of just using arrows when you're looking at your pH, bicarb, PCO2. So if all of your variables are going in the same direction, it's a mainly metabolic picture you're looking at, which is what we have here, right? Our pH is going up, bicarb is going up, our PCO2 is going up in compensation. So all pointing towards a metabolic alkalosis. I guess the next thing to do that I'm not sure we always do is to look at the degree of compensation. The reason this is useful or something that we should be doing is because sometimes you can have like a mixed picture going on, right? We've kind of used that quick, simple step to identify that it's metabolic alkalosis, but that's not to say you couldn't have a secondary process going on. So for our patient, calculating the expected PCO2 using that calculation there, it falls somewhere between 54 plus minus 2. Ours is a little bit higher than that, so would suggest or point towards maybe a possible superimposed respiratory acidosis as well, right? Because our PCO2 is higher than we calculate and that it should be. For the sake of completeness, or I guess the one that we're certainly most used to when we have a metabolic acidosis, using Winter's formula to calculate our PCO2 for that. And then respiratory alkalosis, respiratory acidosis, definitely a lot more complicated getting stuck into that, because obviously you're relying on the kidney's response to that. So it depends if it's like an acute or chronic process that you're dealing with. But this table is quite nice, quite helpful because you have acute and chronic on one side and then acidosis, alkalosis on the other, and a 2x2 table, 1, 2, 3, 4. And looking at the respiratory acidosis, for every 10 points rise in PCO2 that you have, you can expect your bicarb to increase by 1 in acute and 3 in chronic. And then you see 2 and 4 as your fall in bicarb when you're looking at respiratory alkalosis. So I guess for this patient, it was concerning when they came in initially. We could see that even from the BMP that their bicarb was up, like Dr. Singh had pointed out as well. But kind of going through different causes of metabolic alkalosis. I know Andrew had kind of gone through some of these already, so not to labor on about it. But it can happen kind of in two ways. So you either have a loss of hydrogen, which then causes this imbalance or shift where you then end up with like a net gain of bicarb, or you just have straight up direct gain of bicarb. And the places where this can happen in the GI tract or in the kidney. So these things that you identify here, they will all trigger a metabolic alkalosis. But there kind of needs to be something else going on for you to maintain a metabolic alkalosis, right? Because if you have a high serum bicarb, the appropriate response is going to be for your kidneys to just excrete or get rid of more bicarb. But for you to have a persistent or maintain metabolic alkalosis, there must be something else going on in the kidney or affecting the kidney that it's not doing that. So the one that we definitely see a lot of, at least on the inpatient side, is like a contraction alkalosis. So when you have someone who's like dehydrated or volume down with a contraction alkalosis, or even if they have like a reduced like effective circulatory volume, so like our CHF patient, someone with cirrhosis, kind of behaves the same way and will switch on like your renin, angiotensin, aldosterone system. And you'll reabsorb sodium bicarb, so that's how you get your gain of bicarb. And then the other way is activating aldosterone. So where the way aldosterone will work is it will start to reabsorb sodium, but then will dump potassium and hydrogen, which is your loss of hydrogen. And then the other ones kind of operate in like a similar way. So mineralocorticoid excess, same kind of way, you have excess of aldosterone somehow. So like hyperaldosteronism, Cushing syndrome, same way, loss of hydrogen. And then diuretics is kind of an overlap of both of those. So you're diuresing, you're dehydrating, kind of getting a contraction alkalosis type picture. But then you're also getting rid of more sodium. And then by the time it gets to like later in the kidneys, where you have increased delivery of sodium, you might start to absorb some of that, but then you're going to lose hydrogen in exchange for that. And then the other one that we see, and one that applied in this patient, right, was vomiting, losing hydrogen chloride. You're going to end up with the net gain of bicarb in compensation for that. And definitely in our ICU patients or anyone with an NG tube, when you're suctioning frequently, losing your hydrogen that way. And then the last way is somehow directly ingesting or direct gain of bicarb. So milk alkali syndrome, I know, was mentioned. So like Andrew had said, kind of with calcium carbonate compounds, something like that, ingestion or direct ingestion of some other form of sodium bicarbonate. This is just a table going through same things as well. And the only other one that's here worth mentioning is like severe hypokalemia. I don't think it's that commonly seen, like that a severe hypokalemia can cause a metabolic alkalosis, but the idea being like the shifts in potassium and then hydrogen in response to that causing it. And then the other thing, I guess, that kind of comes up a lot is kind of using urine lights to differentiate it, which a lot of them you can see from the history and physical are like pretty straightforward what you might be dealing with. So you can kind of diagnose or differentiate based on that. But I think once they start trying to use urine light, specifically urine chloride, if you're really trying to tell what you're looking at. So like a low urine chloride, pointing towards something maybe that's more like a chloride depletion or volume down, a state that's like saline sodium chloride responsive, so like vomiting, things like that. And whereas a higher urine chloride, you're having some issue reabsorbing the chloride, that you're like dumping it, and looking then at like a mineralocorticoid excess state or some other condition where you're excreting or just unable to reabsorb chloride. And this is just the last thing I have for acid-based things. I really like on NAGM 360, they have two really nice like algorithms for acidosis, alkalosis that can kind of walk you through all of them. And it's just a nice way of making sure you don't ever forget stuff, or kind of having a stepwise approach for that. And with that, I will pass it back to Andrew to kind of tell us how the rest of this case went.
Sure. Thanks, Jackie. So basically going back to his labs at presentation. So, a couple things we can see here just for reference. these were the, initial labs. So, we had already seen the elevated bicarb, the hypochloremia, the elevated BUN and creatinine, and the hypercalcemia. And then, 3 or 4 days later, these were his repeat labs. So obviously we can see that things kind of, continued to trend in the wrong direction. I mean, his calcium was a little bit better, but still elevated. Yeah, so, we already kind of established that this gentleman has so he has an alkalosis that is primarily explained by the elevation in the bicarb. And, just to remind you guys that the bicarb, this is the bicarb we get on a VBG is a calculated value, whereas the one we get on the Chem7 is a measured value. So we would, generally go by this, so it's a markedly elevated bicarb. So it's a primarily metabolic alkalosis with some respiratory compensation, inadequate respiratory compensation because he's still alkalotic. The other things we can see on here. So what, besides the Chem7, what else stands out to you guys on these labs here?
Now his white count is going up. I don't think it was.
Yeah, that's a good point, Yasmin. Yeah, so he has a mild leukocytosis. It was within normal range a few days prior. But this was probably the only, I guess, if we're going by SIRS criteria, he wasn't febrile, not tachycardic.
Tej is mentioning the anemia as well, especially, a really young guy like this, like a hemoglobin of 9.7, and Ariella is saying the new hyponatremia.
Absolutely, yeah. So, the anemia, again, we're kind of treating this gentleman as sort of an undifferentiated case, didn't really have regular medical care. Again, nothing on his history to suggest like, GI blood loss or anything like that. But yeah, definitely like anemia in a male is always a red flag. So that is a good thought.
Also, I had like the hyperphosphatemia. Maybe you might tell us that it's not like PTH driven etiology, just like maybe PTH is suppressed and there is other etiology causing this, because I believe from hyperparathyroidism you get low phos and high calcium. So I think there is something else going on.
Yeah, no, that's an excellent point. So basically the phosphorus is very informative in this case. The phosphate is kind of like, I guess an analogy you could use is kind of like how a specific gravity or, urine osmolarity is kind of a proxy for ADH activity. The phosphate, when you're working up hypercalcemia, because usually these labs tend to come back relatively quickly, like within a couple hours. While you're waiting on the PTH, a high phos suggests that this is a process in which PTH, that is not PTH driven, because if you guys remember, PTH, hyperparathyroidism inhibits phosphate reabsorption, so results in net phosphate excretion at the distal tubule. So yes, the hyperphosphatemia in this case kind of points us in one direction versus another.
Andrew, can I just ask a question?
Yeah.
I agree with the hyperparathyroidism, but I'm just wondering if this degree of AKI could lead to like impaired phosphate excretion, and that could cause an elevated phosphate. I'm just wondering if, like, how
that's true. Yeah, no, Kirtana, that's a great point too. Again, we'll get to the conclusion of the case in a bit. It's very, it's kind of a murky case because it's not, it's kind of we'll see how this is kind of a chicken and egg problem. We don't really know exactly what tipped off what, but that is a good point. The AKI could certainly help explain the hyperphosphatemia as well. So this was, so the next slide. So this is pretty much all the lab work that we collected over the course of a couple of days. Just for context, this gentleman was admitted, I believe, for like 3 days or so total. So this was like, like day 2, 3 of his hospitalization. As I mentioned, because we didn't really have much background on this guy, besides that creatinine of like 1.15 from about 2 years prior, we kind of just, just cast a wide net and tried to work up not just etiologies of AKI, but, just renal failure in general. So if anybody wants to comment on any of these lab results.
Vitamin D, less undetectable. 125 hydroxy.
125 vitamin D, yeah.
Did he inject silicone or something?
No, I think Yaraz asked that earlier. We didn't ask about it, but no, I don't think that was part of.
I might have seen something like that once.
So dollar signs are lighting up in Dr. Singh's eyes, looking at the extensive workup that this patient had.
So
what's the anti-PLA2R?
Anti-phospholipase 2. So basically, that's the antibody that's positive in membranous nephropathy. So again, I'm not, I'm just listing everything. I'm not like listing the sequence at which these were drawn. So I can't tell you like, which lab prompted us to order which lab. I agree. It is a very extensive workup. I think, this, what was I going to say?
Dr. Singh is asking Mantej what he thinks about the light chains, because I think he was asking for that workup.
I think so. They are kind of differentially elevated. If it were kind of purely monoclonal, you'd expect at least one of the normal one to be completely normal. In this case, the lambda and the kappa are high, which could be seen just in a failure of excretion, like in AKI. But having said that, the ratio is still like kind of abnormal. The kappa is more raised than the lambda. So I think, I'm not sure it's like hugely significant. I think it could just be the AKI itself. But equally, I think it might still be worth doing an electrophoresis, maybe, just to see if there's an M spike, like a paraprotein, rather than just the light chains. Maybe.
Is Archana on the call? I can't see her. Are you there?
She was, yeah, she's here.
Oh, she's an expert. She just had a whole lecture about exactly this from the Onc fellow last week. Archana, do you want to comment?
I comment on the
kappa
lambda chain.
Yeah, the kappa lambda ratio and the fact that Mantej now wants an electrophoresis.
Yeah, so looks like if the kappa lambda ratio is here it's 3.5, that's not really concerning for myeloma specifically. So if it's like higher, like I think 7, 8, or above 10, that's more of suggestive this may be. But if we are concerned about this patient having myeloma, I think immunofixation would be a screening test which can be used to see if it's present or not, if we have any monoclonal antibodies at all.
Yeah, that's perfect. And also, Mantej, I agree. When the kidneys aren't working, the ratio is a little skewed, and that's not necessarily exciting about sort of the presence of underlying, monoclonals or light chains, because this creatinine is almost it is 10, and so with CKD, it's probably the most common reason. And I'm not saying this person has CKD, but CKD, even AKI, is the most common reason to see this derangement.
Mm-hmm.
Thanks. I was also just interested, kind of separately, that the parathyroid hormone is normal despite the level of hypercalcemia. So, I mean, should you not expect it to be suppressed? Could this be like an element of hyperparathyroidism, or is it just trying to excrete the extra phosphates? Like, I would expect that to be low if the patient is that hypercalcemic for such a long time.
Yeah,
it is on the lower end of normal.
Right. I should have. Sorry,
it's on the lower end of normal. It is somewhat suppressed.
Okay.
Yeah, sorry, I only included the reference ranges for labs that I flagged as abnormal. But yeah, Dr. Singh is right. The normal is like around like 10 to 60 or something like that. So.
Oh, okay. So it's kind of.
So I hear you, Dr. Singh, what you said about this this being kind of a wasteful workup. You know, I just full disclosure, I saw this patient when I was on the renal consult service. So, you know, my attending that I was with, you know, he obviously not getting much of a, you know, not much of a history or backstory from this guy. Like I said, we wanted to cast a wide net. That's why you see compliments ordered. We kind of, you know, obviously this gentleman does not have a, you know, severely proteinuric AKI. You know, the protein creatinine ratio was 181. But yeah, we did, despite that, you know, we were working on them for like lupus nephritis, membranous nephropathy, you know, the typical workup for other causes of unexplained kidney failure, the HIV, hepatitis B and C. So yeah, nothing really to comment on those. I mean, the CPK is elevated, but not to the level at which we would label this rhabdomyolysis. The troponin, you know, this gentleman had no cardiac symptoms whatsoever. I will pull up his EKG in the next slide. You know, we did get, you know, funny that we talked about sort of working up metabolic alkalosis and getting a urine chloride, and that was the only urine electrolyte we didn't get. Essentially, you know, I think whoever saw him in the ED on presentation just empirically started treating him as he should have with, you know, standing fluids, you know, with like normal saline at 200 cc's an hour. But, you know, going by the FINA, this is suggests points more towards a intrarenal cause, but again, not mutually exclusive with pre-renal, as we'll kind of see in the next slides. And then, you know, there was some mild microalbuminuria, but this was turned out to be transient when it was rechecked at a later time. So this was his EKG. I apologize. I think on my screen it didn't look too. It looked a little bit more clear, but just in the interest of time. So I mean, this is basically like a normal sinus rhythm, maybe with some, you know, flat-looking T waves in the lateral precordial leads. We didn't have a prior for comparison. And then we also got a renal bladder ultrasound, obviously, you know, as part of a standard AKI workup. Did not find any post-obstructive causes. However, they did comment that the kidneys looked like there was evidence of, you know, medical renal disease or CKD. So they had the echogenicity that we commonly see in those conditions. So diagnosis.
I think Dr. Singh called it, and I think Kirtan had called it maybe before. Even.
Yeah, multiple people called it. I had to keep a poker face, but yes, you guys are right. This is milk alkali syndrome. So I will. So milk alkali syndrome is essentially the triad of these three things: hypercalcemia, acute injury, and metabolic alkalosis. Don't get too caught up on the arrows because this kind of suggests causality, which is not always the case, but basically milk alkali syndrome. So just a little backstory about it. It was actually first described about 100 years ago, actually. It was described in, I believe it was a case report. So about a decade prior to that, you know, the thought at the time, you know, somebody came up with the idea of treating dyspepsia or peptic ulcer disease with heavy doses of alkaline or basic substances. So these were the things that were mentioned. I have linked to a review article about milk alkali syndrome at the end of this talk that does mention this. But basically, you know, about a decade after this kind of regimen was popularized, and again, this was like decades before the first, you know, PPIs or H2 blockers ever appeared on the market. You know, about a decade afterwards, there was, you know, a case report of people having adverse effects from this regimen. And this came to become known as the milk alkali syndrome. So, you know, obviously with the advent of with the advent of our understanding of peptic ulcer disease and treatments, this is probably not as common. This is the only time I had ever seen it in a real patient. But it is considered to be the third most common cause of inpatient hospitalization for hypercalcemia, after primary hyperparathyroidism and malignancy, which I'm sure you guys have all seen before. And like I said, it's a syndrome characterized by the triad of these three derangements, usually resulting from an ingestion of large amounts of calcium and absorbable alkali. So in our patient's case, he had a history of ingesting Tums, even though he didn't quite, it was really an unspecified amount. Now, so, the way milk alkali syndrome develops is it's kind of a vicious cycle in the sense that, we don't really know what tips off what. Again, the thing to keep in mind with this patient was that these labs were incidentally discovered. It's not like he presented to the ED like in florid, volume depletion or hypercalcemia with, the classic presenting signs. But essentially what happens is that the hypercalcemia itself, again, we're not sure what came first, but the hypercalcemia, which partly was due to, probably excess ingestion. The hypercalcemia itself can impair the kidney's ability to excrete bicarbonate. And it can do that by several mechanisms. One of them is it can constrict the afferent arteriole at the glomerulus, so decreases GFR. It also, if you guys remember, like in learning about renal physiology and like the, different gradients, for example, like the calcium, there's like at the thick ascending limb where the sodium potassium chloride transporter is, calcium, there's paracellular calcium absorption, and hypercalcemia can sort of disrupt those gradients and cause excess natriuresis, and it can also impair more distally the kidney's ability to excrete excess bicarbonate. So this is a slide. I don't know if you guys have listened to the Curbsiders podcast. There was an episode a few months ago, actually, on metabolic alkalosis, and I wanted to include this graphic. This is sort of a nice graphic from their show notes about metabolic alkalosis in general. So basically, as Jackie was alluding to earlier, metabolic alkalosis generally occurs in two phases. So there's a generation phase, which is the addition of alkali and or the loss of protons, which usually happens with vomiting. So in this gentleman's case, he had both. He had the vomiting as a result of the hiccups, and which he was kind of self-medicating with alkaline substances, in this case, Tums. But in order for the metabolic alkalosis to perpetuate, there is also the kidneys, has to be some defect at the level of the kidneys, which prevents the kidneys from doing what they would otherwise do in response to alkalosis, which is to excrete bicarb. So this kind of sums up a couple of the things that help to inappropriately perpetuate a metabolic alkalosis. One of them is a low GFR. The other one is a hypokalemia. And again, the mechanism for that is a little bit intricate, but essentially, if you guys go back to sort of how, acid-base handling occurs at the level of the kidney, there's potassium hydrogen shifts in like the intercalated cells at the distal tubule, which creates like an intracellular acidosis and like fools the kidneys into not appropriately excreting bicarb. So hypokalemia, so that's why, correcting the hypokalemia if it's present is critical in these patients. Low chloride, which this patient had for sure, and an excess mineralocorticoid activity, which we discussed earlier. So again, I won't belabor the point about, checking urine chloride. I mean, obviously the history was sufficient in this case. We sort of empirically treated without even checking by giving him aggressive volume repletion with normal saline at 200 cc's an hour. Key point here is that, in this cases, a lot of times when we're reaching for isotonic solutions, we are, usually between LR, a quote unquote more balanced solution versus something like NS. In this case, NS is the preferred solution because these patients are literally very chloride depleted. And so, you want to replete the chloride. You want to make sure that you want to basically remove any barriers to the kidney not being able to excrete excess bicarb. So yeah, basically the clinical course. So again, he underwent aggressive volume repletion, NS at 200 cc's an hour. His creatinine, improved rapidly. It went from like 10 on day 1 to like 8 on day 2. And I think it was like 4 to 5 on day 3. Obviously by that point we had gotten our workup, we had our answer. Unfortunately, he wasn't really, cool with staying over the weekend. He was admitted on a Friday. So at any rate, I did follow this patient serially. He did establish care with the kidney clinic. And then interestingly, obviously we got some repeat labs a couple of months later just to see where his creatinine settled out at, and it was 1.84. So for whatever reason, for reasons that we couldn't explain, in the span of like 18 months, this guy basically had progression from a normal creatinine to a creatinine of 1.84, and using the like new CKD-EPI equation, that basically puts him at a GFR of 44. So that sort of puts him right here in this bucket on the KDIGO heat map. He's at a G3B A1 because he has minimal albuminuria, CKD. And unfortunately, I think he was lost to follow-up. I think the last time he was seen was a few months ago. So we're not exactly sure what caused him, but essentially this gentleman had an AKI on unknown CKD in the setting of milk alkali syndrome. So here are the references. I see Dr. Singh linked to it in the chat. And that's it.
Thank you, Andrew, for a fantastic case and a great presentation.
Thank you, Andrew. That was great. Can I just ask, is there a reason why renal didn't think it was just milk alkali and like did that extensive workup? Or
Well,
just wanted to make sure it was nothing else?
Yes, that's, so, if it were just, the thing is, we didn't, there are a couple of like gray areas in this case. Again, the patient didn't really specify, if I recall correctly, we were asking him about like the supplements he was taking, the Tums, he said that, oh, it's been a few weeks since I took them. Again, take it with a grain of salt. But, under normal circumstances, like Tums, so like I actually looked up Tums, like the formula, I think it's like 650 milligram tablets of calcium carbonate. And this is like a fraction of like what you would use in like, a tablespoon of baking soda. So under normal circumstances, like in a patient with normal kidney function with a GFR that's like not 44, generally the body has, the muscles have an ability to buffer this bicarbonate. But in this case, we didn't know that this gentleman had a pre-existing CKD. I think the attending was suspecting that the degree of AKI, metabolic alkalosis, and hypercalcemia was sort of out of proportion to the amount of alkali that was ingested. And so he wanted to work up what was the underlying CKD like while he was in the hospital.
Thank you so much, Andrew. I think if there's no more questions or comments in the interest of time, we can leave it here for today. But thank you everyone for joining.
Thank you, guys.